vascular health in one way or another, because that's the big killer. And again, going back to some work from Gerald London here, in which he looked in patients with CKD at relationships between their vitamin D status and vascular health. And he looked on the left-hand side at the 25 hydroxy and the right 125. So don't worry which is which. They both show essentially the same thing. And we're looking at flow-mediated vasodilatation, which is one measure of vascular distensibility. And so the higher you are here, the more flexible and elastic your vessels are. So you want to be high up, not low down here. And look, the people who are high up are those who've got the highest 25 hydroxy D concentration, and indeed the highest 125 as well. So if I'm a dialysis patient, I want to be up here somewhere, I don't want to be down there. Likewise, I want to be there, not there. And there are a number of other ways of looking at vascular health in this and other studies that he's done that show broadly the same thing. Having generous amounts of native and active vitamin D around seems to be beneficial. Now the problem with all this is that let's just go back one. The problem with all this is that nobody has yet shown that intervening, supplementing with native vitamin D actually improves patient level outcome. So those studies are very tempting. They are, of course, they are not money spinners. They won't earn a lot of money for any potential sponsor, and there's a bit of a difficulty there. But the studies that have been done, the picture emerging is that if you give native vitamin D to these people, it does not seem to carry any benefit unless they are overtly deficient to start with, and have got manifestations of that deficiency. Now, a word about LVH, because we know that LVH in the general population is a serious risk factor for cardiac death and cardiac morbidity. So, why do all our patients get LVH? We know that LVH is highly prevalent in the CKD population, and the mechanisms I just sort of listed some of the important things here. Hypertension is clearly, whatever's going on chemically in uremia, we know these patients are often hypertensive, that clearly is a major factor here. And what's that doing? Well, in the CKD patient, the hypertension is a reflection partly of a resetting of the pressure natriuresis. So the CKD patient, as you know, essentially has an impaired ability to excrete salt in relation to the prevailing arterial pressure. All of us, the higher the arterial pressure, the greater the natriuretic status of the kidney in general terms. And this means that the renal patient, in general, needs a higher blood pressure to achieve the required sodium excretion. So that's one thing, so blood pressure is reset higher for that reason. Secondly, these patients tend to be volume expanded, often quite subtle. I'm not saying they're all overtly edematous, but subtly expanded in many cases. And the third is that many of them have upregulation of renin-angiotensin system activity. It may again be quite subtle, but it may just take the form of not suppressing fully in the face of the volume expansion or raised blood pressure. But the whole thing clearly is a combination that drives up blood pressure. The likelihood of having LVH increases dramatically as your renal function goes down. Here we are, patients here, GFR better than 50. This is a prevalence of LVH in patients with CKD. So these are the ones who've got mild CKD, and you can see it rising rapidly to about 3/4 of the patients starting dialysis already have documented LVH. So this is not a good development. And the LVH occurring in uremia is clearly partly hypertension driven, but it seems to be more florid and has some morphological differences from that we've seen with just straight uncomplicated hypertension. But I'm not going to go into that in detail, but suffice to say that I think that the chemical environment is clearly an additional factor there. And what aspect of that chemical environment might be in play? Well, FGF23 is one of the possible factors driving the LVH here. Listed here, you've probably seen this figure from Miles' walk of a classic effects of FGF23 on bone mineral metabolism in terms of regulating phosphate, regulating PTH, and reducing the synthesis of calcium trimer in the kidney. These are the classic effects of FGF23. And then there's this term, this list of things come to be called collateral damage. So things that have really nothing to do, or little to do, with the classic effect of FGF23, but seem to be potentially involved in uremia. We're talking about CKD progression, LVH, endothelial and other vascular dysfunction, vascular stiffness, and death. I'm going to say a little word about some of those things now. Now, in terms of association, there's a very, very powerful effect of FGF23 on survival. And you can see here, I spoke about a rather steep dose-response curve of phosphate in relation to survival. Well, the FGF23 one out of the right here is even steeper. Again, this is in quartiles. Don't fall into the trap of thinking that if we could find some way to bring the FGF23 down, we would necessarily achieve this massive reduction in mortality. That does not follow, of course. We're nowhere near achieving that anyhow, and we don't know what would happen if we did achieve it. And there might be some unexpected, unpleasant surprises if we did. But looking at the associations with the FGF23, the all associations here, we can see increasing LVH, depending on your quartile of FGF23 you're in. So FGF23 associating with LVH as well as with high mortality. But the question is, and I've said here, is it the villain itself or just a messenger? In other words, is it simply a marker for the fact that the patient's in trouble, or is it causing the trouble itself? This work was done by Miles Wolf's group, and there's a really good paper in the Journal of Clinical Investigation, which those of you who haven't read it, I urge you to have a look at it. It's an excellent paper with a mixture of clinical science and laboratory science in it. And if you look over the right-hand side here, this is looking at mice and looking at injection of exogenous FGF23, untreated, injected with vehicle, and then a huge increase in cardiac weight in those exposed to FGF23. Big change. And I should add, I haven't got the slide here, that if you then treat these animals simultaneously with an FGF23 antagonist, you can block that effect of FGF23. So the fact you can block that with an antagonist suggests to me that it may well be the villain itself rather than just the messenger. That's probably the most powerful evidence around, I think, for the fact that FGF23 is itself directly harmful. Now, just a quick word about myocardial infarction. We're going to go away from CKD-MBD specifically here and talk about this because these patients that we look after do really badly if they have a heart attack, really badly. And this is one of several studies that are out there in the literature looking at the probability of death on the vertical axis over the first year after a myocardial infarction. And here is the outcome in terms of relation to GFR. And here, this is the dialysis patients. These are those in the GFR 15 to 30. These are those who have normal kidney function. And my goodness me, there is a difference there. There's about a 5-fold difference, more than 5-fold, 15-fold difference in survival following myocardial infarction, depending on whether you're on dialysis or not. So being on dialysis is bad news. Being on dialysis and having a heart attack is dreadful news. And it really puts you into an extremely dangerous position. Now, why might this be? Well, it may just be that the substrate, the heart, is already bad, and therefore you further damage it with myocardial infarct, and that may be too much. But the other thing is that there's a lot less intervention by cardiologists in renal patients than there is in normal patients. And this may also mean that effectively they're getting suboptimal treatment. They're not getting what I would say current best care. And so if one looks here, again, look at these, it's slightly confusing, I'll talk you through this one. We're looking at groups of patients on the left-hand side with normal kidney function, and on the right-hand side on dialysis, and various levels of losing kidney function as we go left to right here. And we're looking at the proportion of patients who had coronary artery, had coronary angiography, or no angiography, or had a PCI, or had a bypass surgery. And you can see as you come across from the left across to the right, you get a higher and higher percentage who had nothing done. Normal kidney function, only 18% had nothing done at all, no invasive diagnostic tests. 76% of dialysis patients, 76% of CKD patients. Now these patients, I dare say, are not getting coronary arteriography, partly because people are frightened about contrast. and with good reason, because if you give contrast to this sort of person, you might end up putting on dialysis. No. But be that as it may, there's no doubt that these patients are getting a lot less diagnosis and a lot less intervention in terms of PCI and bypass grafting as well. This may be contributing to their bad outcomes. And the bottom line here is that early intensive therapy is associated, when it's there, with a better survival. But the benefit of that decreases as your kidney function gets worse. And so there is an argument that says that this low intervention may not be quite as bad as it appears, because it may well be that the intervention, when it comes, is less beneficial than it is in the general population. Now, I'm going to close with a word or two about cardiorenal syndromes. I'm not going to go through this in detail. There is a working definition: disorders of the heart and kidney whereby acute or chronic dysfunction in one may induce acute or chronic dysfunction in the other. That's a sort of fairly straightforward working diagnosis. And then it gets more complicated when you start trying to put it all together. And we won't go through this in detail, but I just want to notice that we have on the left-hand side here cardiorenal, on the right-hand side renocardiac, which is really simply the terminology that I think does fit the notion of whether you've got a primary cardiac insult with a cascade developing that will include renal dysfunction down the bottom here, or whether you've got a primary renal insult with a cascade developing that will lead to cardiac dysfunction. The bottom line here is that either of these carries a really bad prognosis. No, this is not a good combination. It's bad enough having a heart that's failing. If you have a heart that's failing and your kidneys don't work, you're much, much worse off, and vice versa. So there's extremely close linkage here between these two. And that simply is the nomenclature that we use: cardiorenal type 1 and 2, purely reflecting whether it's acute or chronic, and then renocardiac, purely reflecting type 3 and 4, whether it's acute or chronic, acute AKI leading to secondary cardiac events, and CKD leading to secondary cardiac events. And then we've got a sort of ragbag of multi-system ones. Let's move on, we all know that, we're nephrologists. So to conclude then, we've got the two visceral organs occupying key positions in the circulation, with a lot of interdependence. And the metabolic disturbances in uremia are absolutely critical, and they lead to dysregulation of cardiac and vascular function on a large scale. And the bottom line here is that a damaged heart is very bad for the kidneys, and a damaged kidney is very bad for the heart. And this is just the gradual coming together of cardiology and nephrology, which has taken a long time. I think one can summarize it like this by saying, when you get to the fork in the road, there was a time when you could say, well, here I am, coming down here, I can either be a cardiologist or I can be a nephrologist. I don't think, certainly when I was at that stage of this fork in the road, I had any idea that by becoming a nephrologist, I was going to end up having to be something of a cardiologist as well. And I think we in nephrology are now getting quite good at this. I think the cardiologists, with great respect to any cardiologists that may be in the audience, are not quite so good at the nephrology, because they're still very, very single organ focused. But I will be willing to debate that with any cardiologist that happens to be in the audience who wants to take exception. So there we are. These are highly interdependent. We have to do both. The cardiologists, I think, have to do both to be fully effective, and that reflects the underlying diseases. Thank you, Liz.
Cunningham for the comprehensive and very elegant presentation. And now time for questions. If you allow me to be the first one to ask. And a question about the vascular calcification, whether medial or intimate. Do they regress after successful kidney transplantation? And to what extent when we compare it with an age-matched group?
Yeah, good question. And the sad thing is that there is no evidence that it regresses significantly as a result of any intervention that one can make. There's no doubt that transplanting early makes vascular calcification much less likely to develop than continuing with dialysis. That's absolutely clear. So transplantation is a very good preventer of vascular calcification, but it does not seem to turn the clot back. nor does anything else we have available at the moment. And my view is that if transplantation can't do it, it's almost inconceivable that anything we do on dialysis can do it either, because transplantation is a much better treatment than dialysis.
Even with the normalization of the internal milieu.
Exactly. You would think, wouldn't you, that transplantation, it's normalizing calcium, phosphate, PTH, FGF23, all these things, uremic toxins, they're all going away. And yet, vascular calcification remains static.
Any question?
Let me ask you a question. I want to ask, how many people in this room take supplemental vitamin D? Hands up anyone. I did this yesterday. Hands up anyone who takes supplemental vitamin D to treat their own vitamin D deficiency, whether or not you measured your own levels, that is.
The problem is that this is not available agent.
Oh, see, okay.
It's routine blood variant.
Yeah.
Here because of the post.
I'm talking native vitamin D, just deep cholecalciferol.
Both of them, most of them are not.
Okay. Right. Out of interest, you heard me say this yesterday, but the point I was going to make, in fact, in countries where it's available, cholecalciferol is extremely cheap. It costs almost nothing. And a show of hands, just like I've been asking for at the American Society of Nephrology meeting at ASN about 2 or 3 years ago, which I was at, about 50% of nephrologists put their hands up when asked, are you taking, hands up anyone taking more than 10,000 units a week of supplemental vitamin D? So the Americans believe it. Most of us here will be at least insufficient though. And if we measure the average 25 hydroxy levels here, most of us will be below ideal. We don't know about that.
Excuse me, regarding giving both native vitamin D
Yeah.
and active vitamin D, what's your comment on this? Because there is a nice trial that was published just a couple of weeks ago showing that they give 50,000 native vitamin D and super plus extraordinary. What's your comment on this?
Yeah. Well, that trial was giving 50,000 units a week of cholecalciferol, I think for the first month, and then 50,000 units every 2 weeks or 4 weeks for another 5 or 6 months, something like that. Now that raised the levels of 25-hydroxy a lot, as you'd expect. There was no patient-level outcome of benefit at all. It was essentially a negative study. But what we do know from this is that if you give significant doses of native vitamin D in CKD, stage 2 and 3, and probably 4, but certainly 2 or 3, you can reduce hyperparathyroidism. And that's probably because the kidney is still able to manufacture a little bit more 125 for substrate. In dialysis patients, I think it's pretty clear that it has no effect on PTH at all. Native vitamin D.
But this the trial was in dialysis patients.
Yeah.
Dialysis and infection trial in New England.
That's right.
Yeah, it's a
Yeah.
great trial.
It's all quite disappointing. There's plenty of scientific plausibility. There's a lot of epidemiological plausibility too. If you look at vitamin D levels in cancer, for example, around the globe, there seem to be quite strong associations. If you look at multiple sclerosis, the vitamin D levels again, strong associations. The scientific plausibility is there, the epidemiological plausibility is there. We just haven't been able to show any effect of giving the stuff, which is very disappointing.
About the availability of the serum levels of active vitamin D. Do you agree to give those native and active vitamin D available levels, especially in a risk group patient like children or
Yeah.
below adolescent?
This is really a really important question. I didn't talk about what constitutes an adequate level of 125 or 25 hydroxy today in the interest of time. But to me, I think you've got a bioassay, namely PTH. So I think that you don't need to measure. I don't think you learn anything from measuring 125 levels when you're treating. You learn from seeing how the parathyroids respond to it. That would be my take on that. So that's your bioassay, essentially. And you know that you don't over-suppress or under-suppress. There's a range there. Now, in terms of 25 hydroxy P, that's more difficult. I'll tell you what we tend to do, and that is we measure the 25 hydroxy level in our new CKD patients, be they dialysis or pre-dialysis. We measure it once, and then if it's low, we start them on cholecalciferol at 20,000 units once a week. We just happen to have a capsule that is that strength. So it's one capsule once a week of this stuff, which is incredibly cheap. And then we measure it once more 6 months later. And if it's within the target range, we then continue it indefinitely and we never do another measurement. And the reason for that is that the medication is very cheap and the assay is quite expensive. So we don't want to do the assay any more often than we have to. So we'll do it once or twice only. Now, if the level hasn't changed at all after 6 months on 20,000 units, we forget because we know that the patient is not taking it. But the level will change if we take it. It may not go quite as high as we want it to. So the follow-up level is then still higher, but not high enough. We then just double the dose to 40,000 and we never measure it again.
Did you measure cancer and phosphorus?
Oh yeah, I mean they will be measured as part of standard CKD follow-up, and the PTH will get measured maybe once a year or whatever, depending on the scenario. Start after 6 months. And I think the stuff is, my take on this is that it's hard for me to see that cholecalciferol supplementation can do any harm. There's an incredibly wide therapeutic window. It's very, very difficult to overdose someone with hypercalcemia. Very difficult. Even a normal person, let alone a dialysis patient who's got vitamin D resistance. You've got to get truly ridiculous doses to do that. So it's very safe. It's much, much safer than alpha calcinol, which of course has a very narrow therapeutic window. It's very easy to go over the top. And that needs a lot of monitoring, as we know, PTH and calcium. So I see it as being one of these things that might, if we're lucky, do a bit of good. We haven't proved it yet, but it might. But it definitely won't do any harm. That's my take.
Thank you.
Okay, thank you very much, Professor Cunningham, for this very interesting lecture. And now we move for the second part of this meeting.
15 minutes.
Now?
15 minutes break, the break is break
Break, 10-minute break? Okay. Okay, so it's 15 minutes.
أول